Thank you very much, Chairpersons, and good afternoon to all of you. At the outset, I would like to thank the Oncology Club and also Dr. Kamal, Dr. Suman, and the Scientific Committee for giving me this opportunity and inviting me. Next 15 minutes or so, I'm going to talk about the incident learning system, a concept which is not very much well known in this part of the world, which is the need of the hour for our countries. I started my career in the 80s, and people like me, we have worked with these kind of rudimentary machines like Cobalt 60 with the mercury shutter system, and LINAC with the 80 centimeter SAD, and also very, very old linear accelerators. And not only that, the machines were rudimentary, but the entire workflow was rudimentary. Like, for example, we never had used thermoplastic marks, and we used to mark the fields with the gentian violet ink, and simulation step was not there in our time. And we used CT for treatment planning. I mean, the use of CT for treatment planning was unheard of because there were no CT at all. And even when we had access to CT later on, only limited slices that we could take, and the slices were of the thickness of 1 centimeter. Contouring was limited only to one slice because TPS cannot take more than one slice. And from the film, we had to move on to paper, and from paper, we had to move on to TPS using the digitizer. And there was no concept of GTV, CTV, PTV because ICRU came in 1993. Only very few centers had a treatment planning system at that time, and RFA was considered as a luxury because that means that beam modeling was not present there in the TPS. There was no HU information. Planning systems used correction-based algorithms only. Model-based algorithms were not there. Plan parameters, once the plan is finalized, you have to note it down manually and then go on and enter it in the treatment machine. And the treatment planning systems were incapable of calculating MUs. Regarding plan verification and treatment delivery, there was no plan verification, there was no imaging at the time of treatment delivery, no setup correction, and there was no R&V system. As if these things were not enough, Varian and Electra had their own coordinate systems. For example, in Varian machine, when the beam is pointing downward toward the floor, the gantry was at 180 degrees. And when it was pointing upward towards the ceiling, gantry was at 0. And Electra, long axis is x-axis, and the short axis is the, AB axis is the y-axis. And there was no IEC 61217. It was published in 1996. So this is what I say that rudimentary machines. You can see the control consoles. They were made up of thumb wheels. So if you have to set 129, you have to use the thumb wheel in order to set the MU. Instead of 129, if you set 921, there is no catch. Patient will be wrongly treated, no catch, nobody can catch that error. Like this is what SL series LINAC. You can see that long axis is the x-axis. So it was like walking through a minefield, literally. In each and every steps, there were many, many possibilities for committing serious errors inadvertently. And believe me, we were committing errors in spite of our best of the efforts. The turnaround came in the 1990s, somewhere around the mid-1990s. What happened? The DICOM came into picture. CT simulators we started using, and we also started using multimodality imaging like PET-CT and also MR. And continual development started happening on the delivery systems, like we had IMRT, IGRT, and SRS, SRT. Everything came, and all accelerators invariably had inbuilt R&V system. And we started having more and better treatment planning system. Standardization of the coordinate system, we had IEC 61217. So if you look at the stimulating factors behind these developments, you can very well appreciate the fact that these are all due to our requirements to improve the accuracy with which we deliver the treatment to the patient, and we wanted to increase the efficiency in the way we deliver the treatment to the patient. And also, more importantly, we wanted to enhance the patient safety. So these were all the driving factors behind all these developments that we started seeing from mid-1990s. But then what happened was that I'm not going to go into these details, but then you can see that along with the new technology came the new error pathways also. So many incidents happened, and all these things taught us that along with the new technology, we should be prepared for some new error pathways. So this made radiation oncology community to look for new approaches to prevent or mitigate the errors. So what did the radiation oncology community do? So they started looking into new approaches for mitigating the errors, like they went into the industrial engineering approaches for preventing the errors. So what kind of approaches? Like these are the different approaches. Proactive risk assessment, like FMEA, reactive analysis events like root cause analysis, and also the reporting and learning, which is going to be our subject, the learning system. So no matter what we try, mistakes will be there. Mistakes are a fact of life. It is the response to the error that counts. Nikki Giovanni, who is a American columnist, writer, and philosopher, who has mentioned this. So if you look at the medical errors in United States alone, there are about 210,000 deaths happening every year due to preventable medical errors. And there is another paper stating that medical errors are the third leading cause of deaths in United States. There have been several rebuttals to this paper saying that the methodology was not correct, but at the end of the day, it remains, there's no denial of the fact that medical error is a serious concern amongst the practitioners. So if you look at the errors in radiation therapy in the United States, it has been estimated that it is around 1 out of 600. That means it is mistreatments per year is about 0.2%. Is this low? 1 out of 600? Is this okay, acceptable, or is this high? You will be surprised to know that this is about 16,000 times higher than the one that we see in airline industry, which is considered as the safest one amongst all industries. 16,000 times higher. Even if we accept the fact that most of the times the errors that happen in radiation oncology are only minor protocol deviations, like in this PMH study found out, 95% of the time it is only protocol deviations. Even then, the rates are about 1,000 times higher than the one that we see in airline industry. And there have been other studies which have quoted several different rates, but no one knows exactly what is the actual rate at which the errors are happening. However, definitely we are one thing sure about, that is the error rate in radiation therapy is worse than other areas like modern medicine, like modern medicine and anesthesiology. So the basis of incident learning system is this, that incidents in your clinic do not happen overnight. It's not like that everything was all right in my clinic until yesterday. This morning I came and then this thing happened. No, it never happens like that. For one major incident, one sentinel event to happen in your clinic, 10 major incidents went unnoticed by you. Perhaps you noticed it, but you did not actually record it. And there were 30 serious incidents which had earlier happened. Perhaps you have seen it, but you haven't taken efforts to learn from it. And similarly, there were 600 incidents that must have happened. You didn't learn. You didn't take efforts to learn. This is the basis of radiation incident learning system. So the theory of incident learning is very simple. An incident happens, on the right hand side, incident happens. So you identify and make a quick response to it, and you report it, and after that investigate, do a causal analysis, and find out what actions you should take in order to prevent such type of incidents from happening in the future. Then put it back into the system. This is what we call it as learning. It's just not only reporting, but also putting it back into the system so that you can prevent it, learning. So I'll just quickly go through some of the systems that are in practice all over the globe. I'm not going to go into the details. This is ROSIS by ISTRO, available since January 2003, one of the oldest systems. This is IAEA Saffron, which again started in 2012. 1,300 incidents reported so far. In Canada, they have got initially for all the medical practices, but then later on they included the radiotherapy also. 40 centers have been included. 3,000 plus incidents have been reported, severe incidents 7. And also they have got in UK, every 2 years, this UK, they are coming out with a report which teaches you lot many lessons. And also in South Africa, they have got this ICON, Independent Clinical Oncology Network, and which includes about 28 radiation therapy facilities. And they found out that the human errors are the most important reasons for causing this kind of errors. In the United States, Veterans Health Administration has got an intranet incident learning system, which is among their centers. I think they have got about 40 centers or so. And there are other incident learning systems all over the Europe. But of all these systems, the most important one is the ROIS in United States, Radiation Oncology Incident Learning Systems. And it was started in 2014, and in the last 10 years, they have included about 875 facilities. More than 875 facilities are voluntarily reporting in this, using this system. 38,000 incidents are there in the database. You can go and analyze if you are part of that. And 60 plus educational, that is learning resources, have been released by Royals. So this is the kind of learning that you take from. Royals comes out with the safety notice if the reported incident is serious enough. They come out with themed reports as and when required, like the training and education, equipment QA, dosimetrically impactful events, and rushing and order or scheduling. Case studies, interesting case studies, that how did they catch that error, and great catches or near misses. So these things are actually coming out in Royals, and every quarter they come out with this aggregate data reports in Royals website. So this is the kind of aggregated report card that they make. And by going through this, you can understand, or you can see that 1/3 of the incidents happen at the time of treatment delivery, including the imaging. And you see here, about nearly 70 to 80% of the incidents happen during this particular phase, that is treatment planning, pre-treatment QA, and treatment delivery, including imaging. So this is the kind of learning that you stand to gain if you have got incident learning system in your country. So if we come to the South Asian countries like my country, your country, we are working in a stressful working environment. A lot of stress are there, which is completely different from developed countries. And we don't have robust mechanisms for QA and many other things. So we don't have robust mechanism designed to prevent errors. And we all work under paper environment. We don't have any paperless environment. And electronic dose prescriptions are very, very rare. And we always have rushed through installations and commissioning. And more importantly, we don't have accreditation culture like the countries in the western side they have got. We don't have accreditation of the departments, accreditation of the radiation oncology practice. So we cannot get the benefits that come along with such type of accreditation. So incidents will keep happening. For example, supposing like in my country, in India has got about 750 Linacs and 150 telecobalt units. That's about 900 units. If you assume that we are treating about 500 patients in a year per unit, this means that we are treating about 450,000 patients in a year. Even if we assume a conservative estimate of 1.5 incidents are happening per 100 patients, according to the different estimates, going by even a conservative estimation, this will amount to about 6,750 incidents a year. And what have we learned so far? Nothing. Just nothing. In our countries, no. We haven't learned anything. So Ladies and gentlemen, the need of the hour in South Asian countries is that we should have a voluntary incident learning system specifically designed for radiation oncology. And when you talk about implementing an incident learning system, it's not easy, particularly considering the fact that we have one of the most complicated workflows. So, where do we have to look into? To look. So, we have to look to these kind of resources. WHO has got one. The RCR, Royal College of Radiology from UK, has got one publication, and similarly in Canada they have got this HTA. So you can look into that document, and also in our own medical physics journal there are recommendations how to implement this. Please look into that. And additionally, this wonderful paper, learning from incidents, from normal accidents to high reliability. So these are the resources that you can look to how to set an incident learning system in your country. So these are the key elements of an incident learning system that should be comprising of commitment to quality should be there from everyone. You create an environment that fosters open dialogue, and errors reporting should be encouraged. It should not be viewed with suspicion, or it should not go to the case of firing the person. Policies and procedures must be followed strictly, and we should have security and anonymity. And these are the components of incident learning system: definitions, process maps, severity metrics, and the casual taxonomies. This is the pathway for implementation. Perhaps initially we should be starting with institutional level incident learning system. Interested large institutions should establish incident learning system in their hospitals, and then they should share their learnings with others and educate them in suitable forums. National level, then later on you go into national level. Respective associations like radiation oncologists, medical physicists, and also technologists, they should come forward and they should together jointly form an incident learning system. Pilot testing should be done to determine the usability. Later on, partner with an IT solution provider, and implementation should be in selected centers. Later on, after disseminating the experience, expand the reach, rope in more centers. And then once you do at the national level, then we can expand to the regional level like the South Asian countries. So national level incident learning systems can teach us how to expand and share experiences amongst us to expand this to regional level. To summarize, when it comes to acquiring latest in the technology, we don't lag behind. We immediately get it. However, when it comes to quality and patient safety, we in the South Asian region, we have so much to improve. We have a long path ahead of us to go further. Incident learning system plays a key role in improving quality and patient safety. There will be significant benefits, especially for a large department with the complex pathways. And if we have only mandatory reporting, like in my country, that alone is not at all sufficient. It's not going to teach us anything. It should be reporting and learning. That's the most important thing. So the need of the hour is a regional level voluntary incident learning system. I owe a lot of my thanks to my gratitude to my teacher who taught me in the 80s, 81. He used to always say, we should be doing something for the patient. We should not end up doing something to the patient. Who else can explain patient safety in a simpler term than this? Thank you very much.